Hi everyone, my name is HVanOpdorp and this is my final project presentation on how I use patient-oriented outcomes assessment in my clinical practice. Patient selection for me was easy. I am the athletic trainer for our collegiate women's lacrosse team and I have 4 athletes and 1 coach with lower extremity injuries, 3 with knee injuries, 2 with lower extremity injuries, so that's who I chose. Let's take a look. My first patient is 3 months post ACL reconstruction. This is her first injury that's ever required surgery or had her sit out for an extensive period of time. She's also a first semester transfer who tore her ACL the second day of practice. So being from New Hampshire, she was a long way from home and felt very alone. Also, she was worried because her best friend had ACL reconstruction last year, and apparently there were some complications and she's still having some issues. Patient number 2 is my senior attacker who had patellofemoral pain syndrome as well as a tight T-band. Our original outcomes assessment happened 2 weeks prior to graduation, so I think that played a role in her health-related quality of life. Like I said, she played attack and has had increased playing time this season. She played about 20 minutes a game last year, and this year has increased to between 30 to 40 minutes per game. She first started complaining of her knee injury during our 5-week span of 12 games, which is a pretty significant load in women's lacrosse. She also had some significant weight gain. From the fall to the spring, she's gained about 30 pounds, which hasn't helped either her emotional or her physical health. Patient number 3 also had patellofemoral pain syndrome, but hers was more an insidious onset due to her medical history. She had bilateral ACL reconstructions in high school, her left her junior year, her right her senior year, and actually came to college and had 4 more months of ACL rehab with me. Last year she had minimal playing time, but this year as a sophomore, she's our number 2 midfield line this year and plays about 30 to 40 minutes a game. So her workload has increased significantly, but she's got a great work ethic. She works really hard, she plays really hard, and she'll do anything for coach or for rehab. Patient number 4, moving on to our lower extremity injuries, is my junior defender who had a posterior tibialis strain that she initially injured last season and caused her to miss about 3 weeks of games last year because of this injury. She re-injured it during our 5-week span of games in March of 2018, but she continued to play through it. Every time I asked her how she was, she's like, well, I'm okay. So tough kid who led our team in ground balls and turnovers this year. Patient number 5 is our women's lacrosse assistant coach. Her main job is to warm up the goalies as well as to run our conditioning and agility program and take the girls through it. She's had sesamoiditis, she says, for about 4 years now, but it's caused a change in her gait and mechanics, which has caused her to get peroneal tendinopathy. She's a recreational runner and actually ran a half marathon 2 weeks prior to the initial outcomes collection. She's a mom of 2 boys, so when she gets home, she's very active. So she says her rest time is minimal. So I chose the SF-12 as my general measure of health-related quality of life. The SF-12 is the downsized version of the SF-36, and it gives us some insight into the environmental and activities and personal domains of the ICF model. It was made to be easier to read and complete than the SF-36. It only takes about 2 to 3 minutes and is meant to be no more than 2 pages long. And it consists of 12 questions which cover both mental and physical health components, all on a Likert type scale, either 1 to 5 or 1 to 3. My region-specific scale is the lower extremity functional scale, which is 20 questions, a Likert type scale, which measures everyday functional activities. Like the SF-12, it's easy to read, easy to complete, and takes less than 5 minutes to complete. You can also go on orthotoolkit.com and it'll actually compute the score for you when you plug in the numbers, and a higher score indicates higher functional level. The left is made to cover body function impairments as well as the activity and participation limitations from the ICF model. So, how I collected the PROs. The first collection was the final week of our spring season, right before our conference tournament. All of the athletes completed them in person. Well, they received post-practice treatment. I gave them a clipboard and they filled it out. The second collection was 3 to 4 weeks after the completion of the season, which was 2 weeks after the end of the semester. 3 of them were completed in person. The other 2 were back home in Maryland, so I had to do it via email, attach the forms, and then type out instructions. So let's look at our findings. The SF12 is a little bit tricky, and the scoring is a little crazy with reverse weighting and stuff, and it depends on age group. So Allison gave us permission to use 4 points as a minimal clinical important change, but also advised us to look at qualitatively. So if you look down at the breakdown, these are how the questions are broken down, and here are the findings. If you look, the total average of change was a positive 10 in better overall health-related quality of life. If you look at my ACL rehab, who is patient 1, she gained 1 point in each subdomain, which in a month of ACL rehab you would expect. Patient number 2, who is my highest, she was our senior attacker. And if you look at her subdomains, it is in the role functioning, especially the physical, emotional pain, but her mental health and social functioning improved. So I'm wondering if graduation, final exams took a load, took a bigger load on her than we anticipated. The others range between 8 and 12. Again, our average change was 10.6. For the LEFS finding, the MDC and the MIC are 9. There was a systematic review done that was by METHA, which showed an MDC of 6 for knee conditions, but 9 is considered acceptable for musculoskeletal conditions. So let's look at our patients. Again, our highest score was our senior attacker, who had a 35-point change in her score. She went from 26 out of 80 to 61.80. Our lowest was our ACL patient, but this is a little skewed because some of the questions near the end talked about running, cutting, pivoting, which she's not clear to do. So you would expect her to have the lowest score. Overall, our overall change was a 22.2 points, which shows improvement for everyone. So reflecting back, the good of this is my athletes were very interested and very enthusiastic in the final results. They gave me good feedback on what they liked, what they didn't like, but I also felt it gave me good insight on how the mental and physical components of recovery after a long season and academic year, especially in your seniors. The PROs were easy to understand. They took less than 10 minutes to complete, and the left score was very easy to calculate, especially with the website. I felt it gave me a good snapshot into the patient-related functional perception, and it almost facilitated a conversation with my patient about what area they felt they wanted to focus on the most. The barriers. In season, especially at the end, it was really challenging to find time to complete it, especially because we practice during the middle of the day and they are running off to classes. They all suggested it would be easier to do it electronically rather than paper. The second collection was challenging because the end of the semester you had to track down the athletes, and I had to nag my senior to please get it back to me. And like I said before, the SF12 score was very confusing. So for the future, I can definitely see myself implementing these, especially for my chronic injuries as well as long-term rehabs, to give me insight. I was able to change our conditioning plan for our athletes with knee pain because I saw that cutting was a problem. So that was a good building block for my coach, for them, and a conversation. I've also begun talks with my program director and head athletic trainer to see if we can implement them into our EMR, and we're also in talks with our EMR programming department. And then the SF12 was used to give good insight to the mental component, which if you start to see compliance or adherence to start to lag, this could be a good idea of what's actually going on. I hope everyone enjoys their summer break. This is where I plan to spend most of mine, on the beaches of Florida. If you have any questions, I look forward to seeing them on the discussion board.